Hi there. My name is Mike Tadman. I'm a specialist nurse in Oxford, and it's a great privilege to be asked to talk at the Neuroendocrine Cancer UK Virtual Summit. I'm sorry we can't all be here in person. It's obviously much nicer talking to an audience and being able to take direct questions, but it's still amazing that this event has been put on. And I'd like to thank Kathy and everyone at the Neuroendocrine Cancer UK team for inviting me to be able to give this talk. I'm going to look at a spotlight on pancreatic neuroendocrine cancer. So the purpose of the talk, when I was asked to give this talk, really the key thing was, what do you leave out? You know, you can't cover everything. So I thought most people here will have some knowledge of pancreatic neuroendocrine cancer. So I want to have a summary of the main aspects of management, and then I'd like to focus on some of the controversies. So looking at how we manage small non-functional pancreatic NETs, where there's some debate about the best way to manage that. And then looking at sequencing of treatment for metastatic NETs. So what drugs and treatment should we give, in what order? And then finally sort of focus on what's cutting edge at the moment. So looking at some of the new treatment trials, looking briefly at the role of immunotherapy, checkpoint inhibitors, and also a better understanding of what's going on inside in the tumor microenvironment. So pancreatic NETs. So they're not rare tumors. We were often described as rare in the past, but I think we're getting away from that now with neuroendocrine tumors. And you can see from the graph there that the increase in incidence over the last few decades, a sort of 4 to 7-fold increase in incidence, shows that they're clearly not as rare as we used to think. They make up around about up to 10% of all pancreatic tumors. And due to the change in how we look at things now in terms of scanning, so better scans, more scanning for and screening for people like with patients with multiple endocrine neoplasia, there's been a trend over the years in the reduction in size and stage of lesions at diagnosis. However, sadly, the majority of tumors are still discovered once they spread either regionally or to distant sites. The great majority are sporadic, i.e. they don't have a genetic inherited disorder attached to them, but around 10 to 30% of them do. And the most common disorder is multiple endocrine neoplasia. And there is also von Hippel-Lindau syndrome and tuberous sclerosis and neurofibromatosis 1. I'm not going to focus on this area, so the talk today is going to be looking at sporadic issues of people with sporadic pancreatic neuroendocrine tumors, and there are other talks in the summit focusing much more on inherited disorders. So there are a range of different tumors, so there isn't just one type of pancreatic neuroendocrine tumor. And one of the ways we split them is into functional and non-functional. So looking at functional neuroendocrine tumors, so all of these tumors emerge from the islet cells from the pancreas. And so a number of them have the ability to secrete hormones. And the specialist functional pancreatic neuroendocrine tumors are typically named after the hormone that they secrete. So you've got gastrinomas secreting gastrin, causing this quite well-known syndrome called Zollinger-Ellison syndrome, causing resistant peptic ulcers, chronic diarrhea, which generally respond really well to PPI, and that's often how we have to manage them. Insulinomas with episodes of hypoglycemia, so causing dizziness, headache, collapse, and patients sometimes having weight gain due to food craving. And again, and those are often managed through simple surgery. Glucagonomas, so secreting glucagon, and they have this rather classic necrolytic migratory erythema, a very unusual rash that patients can get, but also weight loss and new onset diabetes mellitus. And then vipomas, which are exceedingly rare, but have this syndrome of chronic diarrhea and hyperkalemia and dehydration. The majority of the tumors, though, are non-functional. And really, patients tend to present with what we call mass effects of tumor. So this is going to be abdominal pain, weight loss, sometimes gastric disturbance. And those are the majority of the patients that we're going to see often in clinic, because it takes mass effect to cause the symptoms, and sadly these are often diagnosed late because there isn't an early syndrome telling people that they have something. So one of the ways we differentiate different types of pancreatic neuroendocrine tumors is also through grading. So we classically grade in 3 ways. Grade 1 and grade 2 are often regarded as low and moderate grade, and we measure the amount of cells that are dividing at any one time, and we measure this through something called a Ki-67 index. And these are the most common pancreatic neuroendocrine tumors, making up typically around 80% of the overall group. The rarer but still very important group are the grade 3. Now, originally they were all grouped as one, but more recently we've split those into well-differentiated grade 3, so neuroendocrine tumor grade 3 or neuroendocrine neoplasm grade 3, and then neuroendocrine carcinoma grade 3, particularly small cell type and large cell type, and these are typically very aggressive behavior. So there's fundamental different behavior across all the grades. And this is really shown in this slide. So on A, we can see the 5-year survival of patients with different tumor grades, and that's the overall patient population. What you can see is the top line clearly shows that, over 5 years, we've still got about 80% survival. If you go right down to grade 3, you can see that the survival rate drops down below 20%. On B graph, this is actually looking at patients who already have metastatic disease. So even those with spread disease in grade 1, the 5-year survival is better than 60%, whereas you can see with the grade 3 survival is very poor, and grade 2 somewhere in between. In many ways, this sort of graphs are quite self-evident. They fit with other cancers where higher grades tend to behave more aggressively. Though it's helpful to split into grade for these reasons, it's not always that helpful in deciding tumor stratification, as we'll see later. Then the other process is staging. So staging is looking at where does the cancer spread to. Is it localized to one site? Has it gone to regional lymph nodes, or is it spread to a distant site, for example, the liver? And again, we can see that typical with many other cancers, that survival by stage, as cancer spread further at diagnosis, then the survival rates drop. And so 5-year survival in all stages, in stage 1 is around 92%, and in stage 3, sorry, it drops right down to the low 50s. So we have a fair bit of information, but at the moment, one of our problems is that it's often difficult to extrapolate from studies of survival from grade and stage to an actual individual situation. So why is this? So studies, they're often what we call heterogeneous. So the group of patients that are looked at within the study often combine grade 1 and grade 2, or maybe all 3 grades. Patients will have, within a single grade, will have a wide variation in behavior. So you may have patients with very small, low volume disease, whereas you may have a patient with large volume disease with a high tumor burden, very symptomatic, and clearly it would be unusual for them to have a similar survival, similar overall survival. So we really lack a detailed analysis of the nature of disease out of these broad grade and stage information. And it's this that we're going to look at later in terms of thinking, how can we improve the situation so we can have more individually targeted therapeutic options for patients. So this lack of clarity, what does this lead to? So, well, first of all, clearly it makes making accurate patient information sharing challenging. So patients are trying to ask, how does a certain study I've read, how does that apply to me in my situation? We're often not able to give very detailed, specific information. We may give rather vague, broad sense of prognosis and future outlook. It can make the clarity regarding prognosis difficult, and clearly for patients and their families, this can make making major life decisions in this situation very difficult. There's a huge amount of uncertainty, and with uncertainty comes a challenge in trying to regain control. And it can also make choosing the right treatment challenging for physicians and patients alike. What I'm going to look at briefly now is a brief look at diagnosis. Any of you who are listening and have a pancreatic neuroendocrine tumor will know much of this stuff, so it's going to be a bit of a quick run through. So with diagnosis, typically we obviously take a history and clinical examination, which are absolutely essential, and we'll do a range of biochemical tests, so standard bloods, standard biochemistry, but also classic tests like chromogranin A, which is a form of tumor marker, and also fasting gut hormones in pancreatic neuroendocrine tumors to try and clarify whether someone may have a functioning pancreatic neuroendocrine tumor. As you can see in the slide, chromogranin A has a number of problems. It's not very specific, and it's raised when people are on drugs like omeprazole, lansoprazole, or in atrophic gastritis, people with renal failure, and it also doesn't raise typically insulinomas. It can correlate with top tumor burden, but the correlations are by no means perfect. And however, if you have a raised chromogranin A, there is some sense that it can predict progression-free survival and overall survival if it decreases when we start treatment. Other studies we're going to look at are imaging studies. So most patients will have CT and MRI, and of course they'll have a functional scan trying to see whether the tumors have somatostatin receptors, and typically now the gold standard for that is a PET dotatate. The absolute gold standard for diagnosis is still histology, so taking tissue either in a biopsy or through excision of the tumor through surgery. It's a complex process. It can lead to even longer time to diagnosis and treatment, and that can be difficult. Obviously, very difficult for patients who may have spent a long time getting to, say, for example, a specialist centre or a hospital in the first place. And we would always recommend that patients have referral to a specialist centre to work this up. Looking at imaging, really just showing this just to show why it is so obvious that gallium-68 PET dotatate scans are the gold standard compared to previous octreotide scans. Both these scans show a patient, and the scans are taken, same patient, scans taken only a few months apart. And this isn't defining progression in disease, it's just showing the more sensitive gallium-68 scan on the right, picking up vast amount of bone mets, and also showing that the disease is sensitive to somatostatin receptors, and therefore patient would be able to be put forward for treatment such as PRRT. So there's clearly improved sensitivity, increased tumor uptake, and reduced radiation. And from a purely practical point of view, octreotide scans are typically done over 2 or sometimes 3 days, whereas a gallium-68 PET dotatate scan is done over a couple of hours, and that makes a huge difference. So on to treatments. So like many other cancers, if you can, resection of the tumor primary tumor, and if possible, metastatic lesions should be carried out. It gives the best chance of long-term survival, and in certain cases it will provide cure. And we will look at one of the more controversial areas around this shortly. We're also going to have to consider how are we going to improve and maintain the patient's quality of life. The reality is many of the patients we look after have metastatic disease. So quality of life, medical control of patient symptoms, and control of tumor growth are all going to have to go hand in hand. This is the first area I'm going to look at, the localized disease surgery. So as I've said already, resection provides large survival benefits in patients with functioning tumors. It's the best chance to cure syndrome and to increase oncological outcome. For example, patients with single insulinomas will typically have surgery where they may just enucleate the tumor. So tumors taken with a small bit of tissue, and that's sufficient to often cure them for life. In other functioning tumours such as gastronoma, you may have more extensive pancreatic surgery, with lymph nodes, typical oncological resection. But again, the best chance to try and get rid of the syndrome is Ellison syndrome, often in this case. And if patients have large non-functioning tumours, which may well be causing symptoms, a mass effect, if they can be resected, then that is the way to go if possible. So if a patient's fit enough and wants to have surgery and there's an expert enough team, that's the right thing to do. What about non-functioning small pancreatic nets? And I've used the size of less than 2 centimeters to start with. Should we do surgery or should we observe? So what's the debate really about? Well, if we've got a small asymptomatic tumor and it's not causing any problems, therefore, the question is, will it continue to do that? And will it do that over many, many years? If it's going to do that, and if we knew that, then the risk of overtreatment is obvious. So unnecessary surgery for an indolent lesion and the morbidity of early pancreatic surgery. Pancreatic surgery comes with a number of problems, both endocrine and exocrine. So you can end up with diabetes with all its long-term implications, and you can end up with a number of complex gut symptoms because of gut intolerance, diarrhea, and these can have a really big impact on quality of life. However, if we're not sure that a tumor is going to behave indolently, and this is the other side, there's a risk of undertreatment. What if the tumor is going to progress or metastasize? We then have missed the chance to cure more aggressive disease. We've risked a chance of reducing there's going to be a risk of reduced overall survival. And also observation is really going to require serial imaging, so scans basically on a yearly basis typically, and potentially for life. What do the guidelines say? Well, as we often see in the world of neuroendocrine tumours, guidelines vary. The National Comprehensive Cancer Network suggests that any tumours over 1 centimetre, so any small, even if they're asymptomatic, should proceed to surgery. ENETS is slightly more complex, and they suggest with patients with a tumour under 2 centimetres that if they're grade 1, low grade 2, they're in the pancreatic head, there's no signs of malignancy on imaging, then we can stick with no surgery. They also suggest that if tumour grows to 2 centimetre size, or if a tumour is showing concerning growth, and they typically find that as more than 5 millimetres between scans, so that might be a 6-month scan or an annual scan, then they would recommend surgery. So not just guidelines, but other studies, so registry data, for example. So the registry data in the USA have been looked at. They've tended to come down fairly heavily on the side of surgery, but when you look at the data, it's actually quite biased. Cancer databases tend to have a bias towards more aggressive tumours. There's a bias of insurance selection in the USA. You can't clarify on a registry whether patients were actually asymptomatic, so you may be looking at a different group. So patients may have had surgery because they're getting symptoms. And actually, the arms in some of these studies aren't truly observational, in that some patients, as you look more in depth, have been on treatments such as radiotherapy or chemotherapy. Other studies have inherent bias, which is very difficult to rule out, such as physician choice, patient choice, and this all makes it very difficult to get a really clear answer. So how do we decide? Well, I think it's clear from the literature that the specific size cutoff remains to be clearly identified. So really, it's a decision that should be balanced with a number of things. So the patient's comorbidity and risk of postoperative death and life expectancy. Clearly, if someone has a number of complex comorbidities, then the risk of surgery may be too great, and that would certainly push you towards observation if possible. Patient preference, and this is what I often find in clinic. Actually, the patient, when we're sitting down, that patient's viewpoint is so important. Some patients are happy to go through observation, feel comfortable that as long as we've taken the right decision and we're doing regular imaging, that we're going to keep them safe. I've also, on a number of occasions, met people who really, despite any evidence, are really struggling with the concept of living with a small tumor in the pancreas, and the worry, the concern of living with that actually drives the decision very much. And so it's really important that we sit and spend time talking clearly with patients in clinic about what are the pros and cons of surgery, what is the downside. So, for example, tumor location. A tumor in the tail of the pancreas may lead to not the right word, an easier operation, but an operation that has less risk of long-term complications. Whereas a tumor in the head of the pancreas may lead to major surgery, such as a Whipple's operation. So the risk of postoperative pancreatic fistula, postoperative morbidity have to take into account. Hopefully, though, in the future, we'll be able to get more information about splitting up the sort of broad categories we use at the moment, just using tumor size and grade if we've got it. Hopefully we'll be able to get more information about tumors in the future, about the genetic alterations in individual patient tumors, which might help us tailor our treatment decisions much more accurately. A recent study caught my eye in looking at this, and this is something we've also been discussing locally across a number of teams in the Wessex area, was, is there another way? So to coin Tony Blair's phrase, a third way. There's a study in the ENETS 2020 abstracts, somatostatin analogues or active surveillance in sporadic, non-functioning pancreatic neuroendocrine tumors. What this study really did is it took a small group of patients, 41, and 24 of them ended up in the somatostatin analog group and 17 in the active surveillance. And what this showed was that progression-free survival was longer in the somatostatin analog group than in the active surveillance group, and not inconsiderably a group of patients, so 25% in this, and the numbers are of course small, in the somatostatin analog group also achieved a partial response with similar quality of life in both groups. Their conclusion was that somatostatin analogues could delay tumor progression and distance spread, alternatively to pancreatic surgery, and therefore avoiding post-surgical morbidities. So it'll be interesting to see whether this becomes something that becomes more common in practice, but clearly, more studies are going to be needed. This is one group of 41 patients. What I'd like to move on to now is to look at treatments for advanced inoperable, I put ENETS there, but this should have been pancreatic neuroendocrine tumors. So there's a whole range of options here. So medical therapy, we've got somatostatin analogues, so the 4-weekly injections, lanreotide and octreotide. Molecular targeted therapies such as everolimus, an mTOR inhibitor, and sunitinib, which is a tyrosine kinase inhibitor, and also systemic chemotherapy. And then we have some of the targeted therapies into the liver, such as local regional therapies, such as radiofrequency ablation, and also other options such as embolization, chemoembolization, and radioembolization. And then PRRT, using lutetium dotatate, so Lutathera treatment. And finally, of course, some other cancer treatments such as external radiation for patients who might have, say, bone or brain metastases. This is sort of based on adapted from ENETS guidance, so therapeutic systemic options for unresectable pancreatic NET, and not necessarily in any particular order. But though often first line is lanreotide, but this is obviously with patients who have to have somatostatin receptor positive status, and typically would be grade 1, low grade 2, so typically cutoff of Ki-67 of 10%, and often with low tumor burden. And then in chemotherapy, the most common sort of examples are either streptozocin 5-FU or strep-Kate, or sometimes temozolomide Kate. And again, these are often used in grade 1 and 2 with patients who might have progressive disease in the short term or higher tumor burden. Other options are everolimus, I've said, patients who may have a contraindication for chemotherapy. It also works well with insulinoma, has a side effect of increasing blood sugars. And patients respond well to that. And then sunitinib can also be used, which is a tyrosine kinase inhibitor, again for patients often contraindicated for chemotherapy. And then for other patients with somatostatin receptor positive status, as a second-line treatment, we can also use PRRT. So what do some of the really up-to-date guidelines show in this? So this is the ESMO guidelines from earlier in this year. And looking at the graph first, sort of the algorithm here, so you can see pancreatic NETs at the top, and then going from the left, just sort of following the idea of patients with low-grade NET, grade 1, and stable disease or slow growth, they recommend starting with somatostatin analogs. And this is really looking at the concept that if patients are with stable disease, if they're well, then maybe the tumor burden's not too severe, then somatostatin analogs are often well tolerated, and therefore starting with something that's not too toxic. NET grade 2, higher than 10%, they suggest, and this is because they expect this disease to behave more aggressively, that you should start with a different therapy such as chemotherapy or one of the targeted therapies, everolimus or sunitinib. And with NET grade 3, the evidence again is on chemotherapy alone here, though again there's 2 regimes offered. And again, if you come to the column on the right, then what that's showing is that if you haven't got somatostatin receptor positive disease, then the somatostatin analogs are out, and so you're really, it's one of the options of different types of chemotherapy or different targeted therapies. One of the striking things, though, is that really no one knows when you come to the option of chemotherapy or everolimus or sunitinib, which drug should we use first, and which patient will benefit from which approach. So broad suggestions such as degree or pace of growth, which are rather subjective, higher versus lower tumor burden, which again can be quite subjective, and often actually physician preference may well come into what is chosen. And actually, though it is always shown above PRRT in this diagram, there are a number of centres who may well go straight to PRRT on progression of patients on the somatostatin analog, or may like to use PRRT in the higher, in grade 2 or low grade 3 even. So there is a lot of debate out there about really what is the best sequencing of treatment. So looking a bit more in detail at some of those treatments. So first of all, chemotherapy. So cryptozocin 5-FU has been around for many years in the setting of neuroendocrine tumors, and typical response rates, so shrinkage disease on scan, typically are around about 30 to 40%, and in pancreatic NETs. And it's been a standard treatment for grade 1 and grade 2 pancreatic NETs for many years. Temozolomide capecitabine is more recently used, but has shown in retrospective studies has shown similar rates. But as you can see, there's no trial comparing them directly. Similar problems here with everolimus and sunitinib. So 2 treatments that at a very similar time, 2011, there was 2 classic studies that came out. So the RADIANT-3 study looking at everolimus and then sunitinib, both published, as I say, very close together, and showing that there's a good progression-free survival comparatively in treatments of both drugs versus placebo. So in the everolimus study, progression-free survival improved from 11 months from 11 months, from 4.6 months in the placebo arm, and in sunitinib, 11.4 versus 5.5. But again, no trial comparing them directly. So in this situation, you may find physicians will look at the side effect profile and comorbidities of the patient and decide which treatment may be better. What's not on the slide, though, is that their response rates are typically lower than chemotherapy, much lower than chemotherapy. So you're looking typically in single figures. There is a trial going on, the Sector trial, which is randomizing patients to everolimus followed by streptococcus 5-FU or the same drugs in reverse order. And this is something that may help determine sequencing issues in the future. So where does that leave us? Well, we have a fairly wide-ranging toolkit, which is great. So, a number of treatment options for patients with pancreatic NETs. But what we don't have is a clarity on which tool to use first and in which order to use them. We also lack some precision to determine who is most likely to benefit from each treatment. And so we're using really broad criteria, patient performance status, their grade, their KI67. So it comes down to often a combination of broad expert decision and really, sometimes, patient preference as well. So phrases such as degree and pace of growth are often used. Higher tumor burden may well typically suggest use of chemotherapy, but these are really broad concepts, and no one's really tested them out in studies to confirm which treatment is better. Slow rate of progression, we will often advise everolimus or sunitinib. It's suggested that they're better tolerated. My experience is it's not as simple as the targeted therapies are better tolerated than chemotherapy. I've seen the opposite in a number of situations. Some patients actually tolerate streptococcus 5-FU chemotherapy very well and struggle on those other drugs. So we're really using a combination of expertise, but without often the really robust evidence behind how we manage this. This also drew me to another study, which was on the Neuroendocrine Cancer UK website, which is really important here because we're talking about lack of evidence for treatments and sitting with patients trying to decide treatments. Then it's really important that we have a much better understanding of patient preference in neuroendocrine tumor treatment. So this is the ENETS study, which is currently running from, I think it was towards the end of September through to early November. And you can see this on the Neuroendocrine Cancer UK website, and there's a link to it. So it'd be great the more people get engaged in this, and we have a look at understanding what it is that drives patient preferences in different treatments. So how can we improve this situation? And this leads really on to the next element of my talk, which is looking at something called the tumor microenvironment. So a complex image there, and I'm not going to go through it in tremendous detail, but really the sort of change in knowledge has been that previously tumors were often thought of as an insular mass, and really now they're thought of as a tissue that interacts in a complex way with surrounding cell tissues. And this may be different chemicals which help the tumor to grow, so different growth factors such as vascular endothelial growth factor or platelet-derived growth factor, and then how those interact with the cell signaling in the pathway. So how do they provide proliferation, and then how do they allow tumors to develop blood vessels, a process called angiogenesis, which therefore allows them to not only grow but to spread to distant sites. So a better understanding of these can lead to a range of new therapeutic approaches. So how do we target the tumor microenvironment? Well, by targeting it, what we'll hope for is a better differentiation between individuals who currently might be regarded as having the same type of cancer. So, for example, as we've looked at earlier in studies, we may have a lot of patients with low-grade pancreatic neuroendocrine tumor, but we know that the variation in behavior is significant within that group. So at one level, they clearly don't have the same type of cancer, even though at the moment we say they do. And this is really an infancy in this area in neuroendocrine tumors. But even in my time as a cancer nurse in other areas, I've seen an enormous change elsewhere. So for example, in breast cancer, when I first started out, Herceptin wasn't a name drug, but still had a number, and was being trialed at a very early stage in patients with HER2-positive breast cancer, generally had a very poor prognosis. But that's one drug that's made a significant difference to that group. And more recently, sort of like, again, a liquid biopsy type approach in breast cancer has allowed large quantities of women to stop having adjuvant chemotherapy after surgery because it's been shown to make no difference to their overall survival. So we know that precision medicine in some of the common cancers is starting to drive really big changes. And it's really important to see how we can find that happening in the world of neuroendocrine tumors. So we can identify critical therapeutic targets. So overexpression of growth factors and the receptors, such as some I mentioned, vascular endothelial growth factor, platelet-derived growth factor, and fibroblast growth factor. And we already target some things in ENETS already. So we have mTOR inhibitors, so everolimus, the tyrosine kinase inhibitors such as sunitinib, which target some of the above. And of course, before that, we've had somatostatin analogues, lanreotide and octreotide, which target the overexpression of somatostatin receptors. So we're targeting things that impact on angiogenesis already, cell signaling pathways, and proliferation. And these areas are crucial role in NET progression. So what's happening now? So what's at the cutting edge in terms of some of these aspects of the tumor microenvironment? I'm going to look at a couple of up-to-date studies now, which have, are showing some of the new research that's going on. So the first one is a talent study which presented in 2019 using lenvatinib. And it's a vascular endothelial growth factor receptors 1, 3, and fibroblast growth factor inhibitor. And what this study showed was an overall response rate of around 42.3% for PanNETs, or pancreatic NETs. And what's interesting in this study, they were already treated with another targeted agent. So this was patients who've already progressed after having either everolimus or sunitinib and then going on to another drug. And then more recently, presented at ESMO and actually now just out in the Lancet Online journal, got the findings from the Chinese SANET-P study, which looked at surufatinib. And this is one of the first of the new tyrosine kinase inhibitors to show statistically significant benefit in pancreatic NETs in a phase 3 trial. So this was a study of 172 patients who randomized to receive surufatinib, which was 113, or placebo, so a 2-to-1 randomization. And the difference you can see is progression-free survival on the drug was 10.9 months versus 3.7 months for placebo. So I mean, you might see some similarities in the sort of differences in progression-free survival that have been shown in, so for example, RADIANT-3 and also studies of sunitinib. What do these add? Well, they add to the toolkit of treatment. It may be that as another drug option for patients, instead of everolimus or sunitinib, we now have something else, or a range of other drugs we can offer. What we have to remember is they also add in a range of treatment-related side effects, and targeted drugs such as tyrosine kinase inhibitors have a number of difficult and challenging side effects, maybe different from some of the traditional chemotherapies, but very real nonetheless. So, for example, that recent study, hypertension, 38%, and this was, a grade 3 level. So this isn't just minor hypertension, but quite severe. And then proteinuria, and also treatment-related serious adverse events. And in a study, serious adverse event would typically be someone often coming into a hospital for a reason. We're up at around about somewhere close to a quarter. So clearly some real issues there. And one of the issues with the studies that's really important to bear in mind is there's a lack of quality of life review. So there's a look at symptoms, but we don't really know what impact they had on quality of life. But what's exciting is a proportion of patients in both studies had previously received targeted therapies. So this shows evidence for a tyrosine kinase inhibitor being effective after progression, for example, of an mTOR inhibitor. And so that potentially not only just adds an option, but a different line of therapy, so further line of therapy. And if we're going to look at sort of new trials, then it would be remiss not to mention immune checkpoint inhibitors. They're in the news a lot on most cancer blogs and many cancer websites, and certainly in clinics we discuss these very often. So what are these drugs, and what's their role in NETs? Well, so the diagrams really shows that immune checkpoints inhibit the T cell immune function, and then this, by suppressing the immune system, it results in increased immune evasion. So the role of the drugs here, so as you can see in the first slide on the left, that you have PDL1, so program deaf ligand 1, binding there to program deaf 1 receptor, and you can see that inhibits the T cell in killing of a tumor cell, which we don't want to happen. We want tumor cells to be killed by T cells. And if we can find drugs that block either PDL1 or PD1, then we can hopefully increase the ability of T cells, so the immune system, to destroy cancer cells. And these were a massive development in melanoma a number of years ago now, and also been shown to be exciting development in non-small cell lung cancer. Both two cancers that were very limited response to chemotherapy in the past. One of the things that's really important is to know that they correlate well with what we call high tumor mutation burden. So this is when you look at tumor cells in a given cancer, the rate of mutations within the DNA. So the more mutations, so the more deranged the DNA is, then the more these correlate with in terms of potential benefit. Unfortunately, when we look at most low-grade neuroendocrine tumors, they have a low tumor mutation burden. So 3 recent trials sort of bear this out, that in most of the low-grade NETs, these immune checkpoint inhibitors are unlikely to have a major impact. This is a keynote trial with patients treated with pembrolizumab, and there were really only partial responses in 4 patients, 3 pancreatic and 1 rectal. And interestingly, they all had PD-L1 negative tumors, so there was no correlation at all with PD-1 expression. So limited anti-tumor activity in previously treated advanced well-differentiated NETs. The DART trial is looking at GI NET, not pancreatic NET, but it's important to sort of show, for similar reasons, that there was a response only in the high-grade neuroendocrine cancer, where there was a response rate of around 44%, which would, you might bear out similar to other aggressive cancers, but with a poor efficacy in the well-differentiated forms. And then more recently, the June trial, using PD-L1, but also CTLA-4 checkpoint inhibitor, and durvalumab and tremelimumab. And in this, we can see that the cohort of pancreatic NETs, grade 1 and grade 2, only had a 6.3% radiological response. So I think in summary, for these drugs, the role of them is unlikely to be of a significant benefit in low-grade NETs, and there just is no obvious correlation between efficacy and PD-1 expression, and this bears out the fact that it's more likely to be a correlation between tumor mutation burden, and therefore in the future the role they may well have, and it's going to be really important to discover new treatments and develop new treatments for high-grade neuroendocrine cancers, because at the moment there are limited effective treatment options. So it's more likely that the role will be in that setting. So it'll be, I think there will be a number of trials will progress in that area, and it will be combinations of drugs that may well be what we'll be looking at in the future. So what about other developments? We'll get towards the end of the talk. So there are a whole range of developments, and we couldn't cover them all, and a number of them will be covered in other talks in this summit anyway. But a couple of things that are really important when we start to think about precision medicine, which we've talked a bit about while looking at the trials and different treatments, is liquid biopsies. And the one that is being talked about a lot is the NET test, so this multigene expression-based assay. And the problem we have at the moment is we have really limited range of accurate prognostic markers, and ones we use, chromogranins and gut hormones, and compared to them, that is shown to be superior to current markers in a range of studies with a much higher sensitivity and specificity, and therefore in principle could be used to really help decide on situations such as adjuvant therapies post-treatment, to look at early relapse and therefore early development of treatments for patients who may have relapsed. So this is definitely one that's really potentially exciting and we need to keep an eye on. And then more sensitive imaging. We've kind of got used to now that gallium-68 scans are the gold standard, and as is always, there's more development going on, and one of the new areas is looking at radiolabeled somatostatin receptor antagonists, and showing in this example higher tumor uptake, detecting more metastases. And I know there's also been abstracts showing using these in a treatment modality as well. And thinking of PRT, I know there's also looking at using alpha emitters in PRT. And again, these may well be covered in other talks and aren't really room for a talk here. So lots of potential exciting developments will be continuing to happen. So the future. Well, I think anyone who woke up on January 1st this year and predicted the future in 2020 in the world, in the UK, is a better person than I am, because I certainly didn't see how we're going to be spending 2020. But it's always exciting to think about how might things move in the future. So, like in some of the more common cancers, I alluded to the changes in breast cancer over the last 25 to 30 years, we're going to see more precision medicine. We're going to see better differentiation between current broad categories of pancreatic NET. So patients and clinicians will be able to sit down and have much more accurate prediction of what treatments are going to work, what treatments may not work, and therefore tailor treatments and investigations more effectively for patients. So more accurate diagnosis, more individually targeted treatment plans based on that improved understanding of pathology and the tumor microenvironment. I mentioned these already. So adjuvant treatments, early detection of recurrence. And also importantly, the reduction of unnecessary or toxic treatment when it's unlikely to be of benefit. And as I said earlier, for example, in breast cancer, that's been a massive change to be able to prevent a huge amount of women annually, getting cancer chemotherapy when it's been shown to be unnecessary. And of course, if we do all of those things, it leads to a better quality of life. And this is our wonderful NetNata group last year on its canoe trip, and better overall survival. Thank you.